In this video, we'll talk about the basics of revascularization procedures in the lower limb. Lower limb revascularization procedures are becoming more and more common. As a medical student or junior doctor, you aren't expected to know the individual details of each step of each procedure, but it is helpful to have a broad general overview so you have a rough idea of what you're dealing with when you're faced with a vascular patient who's had a procedure. Broadly speaking, we can divide revascularization procedures into open surgical procedures, endovascular procedures, or hybrid procedures in which an open component is combined with an endovascular component to restore flow. Vascular interventionalists tend to divide the circulation of the leg into three distinct anatomical levels. At the very top, you have the aortoiliac level, made up of the aorta, the common iliac, and external iliac down as far as the inguinal ligament. Between the inguinal ligament and the knee, you have the femoropopliteal segment. And then below the knee, you have the infrapopliteal segment, which includes the tibioperoneal trunk and the three tibial vessels, anterior tibial, posterior tibial, and peroneal. In practical terms, as you move from the aortoiliac segment down to the bottom of the infrapopliteal segment, endovascular procedures become trickier and trickier, open procedures become trickier and trickier, and the durability of all the procedures falls. When it comes to lower limb revascularization, it pays to remember basic plumbing principles. Just as there's no point in a plumber doing a brilliant job on the pipe in your kitchen if the pipe next door in the utility room leading to it is blocked, so there is very little point doing a beautiful angioplasty in the below-knee tibial vessels if you've left a really tight stenosis in the iliac artery at the top of the leg. Instead, always work from top to bottom. Correct the most proximal disease first. If the patient has rest pain or claudication, correcting this top level of disease may well be all that you need to do to improve their symptoms. But if they have tissue loss, it is essential that you establish inline flow all the way from the aorta down to the level of the tissue loss. And in most patients, this then means you need to treat all three levels if there is disease present there. Always, though, try and keep it as simple as possible. Do the minimum amount needed to get your patient out of trouble. Procedures that might be considered in a patient needing lower limb revascularization can be broadly divided into bypass operations, endarterectomies, or angioplasty and stents. Bypass procedures tend to be used if the patient has a long blockage or if they have multi-level stenoses and blockages. In theory, a bypass can run any length, all the way from aorta down to the ankle if need be. But in practical terms, the longer the bypass, the less likely it is to be successful. An example of a common bypass is an aortobifemoral bypass. This is a procedure that we use for a patient who either has a long occlusion of an iliac artery or has multi-level stenoses throughout the iliac system. We open the patient's abdomen through a midline laparotomy. We stitch a plastic graft onto the front of the aorta above the level of disease. The graft has two limbs which are then run down through the retroperitoneum just in front of the native iliac arteries, passed under the inguinal ligament and stitched onto the front of the common femoral artery. Fem-pop bypasses are also done, either for long occlusions or multi-level stenoses. We can undertake a fem-pop bypass either with prosthetic or with vein. If we're bypassing from the common femoral to the superficial femoral above the knee, we tend to use prosthetic because there's no difference in patency rates between prosthetic and vein above the knee. But once we move below the knee joint, vein performs better in the long term, so we preferentially will use vein for below-knee bypasses. An endarterectomy is a procedure where we directly open the artery and clear the plaque out with a device a little bit like a spoon. It tends to be particularly handy for calcified lesions or lesions which are very close to the branch points of the artery. And in the leg, most often an endarterectomy is used in a common femoral artery. At the end, the front of the artery is widened by stitching in a patch, and a lot of the time, a common femoral endarterectomy is needed to facilitate a bypass further down the leg. The third broad option for treating lower limb arteries is transluminal angioplasty or stenting. When it was first introduced, transluminal angioplasty was mainly used for short stenoses or very short occlusions. But as time has gone on and experience has been gained, transluminal angioplasty is used increasingly in longer lesions. Angioplasties are performed through an access port that we place in the artery. The access port is called a sheath, and they come in various different sizes. Ideally, they are placed under ultrasound control, although they can be placed under anatomical landmark guidance. Ultrasound control reduces the risk of complications from putting the sheath in the wrong spot. In order to treat lesions above the inguinal ligament, we usually put the sheath in the common femoral artery facing up towards the heart. And in order to treat lesions down the leg, we place the sheath in the common femoral artery facing down the leg through the superficial femoral artery. Once the sheath is in place, I would generally shoot an angiogram to confirm the state of the vasculature before undertaking any manipulation. You then pass a wire across the lesion. In the case of a relatively short lesion, such as in this patient's right-hand side, the wire usually passes easily. In the case of a long occlusion or multi-level stenoses, sometimes you need to pass the wire subintimally, which is a little trickier. Once you're across the lesion with the wire, you cross it with a balloon, inflate the balloon, and then repeat the angiogram to assess the result. Transluminal angioplasty can also be used in iliac lesions. For iliac lesions, though, a lot of the time, once the lesion has been crossed and ballooned, we will tend to place a stent, as this often has better long-term patency rates. For femoral lesions, stents are only placed in very certain specific circumstances, such as angioplasty for a recurrent stenosis. Most practitioners don't place them routinely. As we've mentioned in earlier videos, vascular patients tend not to be the fittest, and patients with chronic limb-threatening ischemia tend to have lots of comorbidities. This means in practical terms that you can do an absolutely technically perfect revascularization procedure and still have a patient run into problems from major complications in the 30 days or so afterwards. These include loss of the limb, heart problems like myocardial infarction or cardiac failure. Some have disabling strokes, and cardiac failure, heart attacks, and strokes do sometimes lead to death. Other occlusions include renal failure, bleeding, infection, reocclusion, and pseudoaneurysm. So it's very important to counsel the patients appropriately regarding the potential complication profile of their procedure. Open surgical approaches and endovascular approaches have advantages and disadvantages. So for every patient, you need to try and pick the most appropriate option for that patient. Open surgery requires an incision. That itself leads to greater scarring, which may complicate further subsequent procedures. Most of them need to be done under general or spinal anesthetic. The recovery time from the procedure is longer, but open repairs probably do provide a more durable long-term result. In other words, the patient gets a longer period without vascular problems. Endovascular has the advantage of a percutaneous approach with minimal scarring so that future procedures are not being inhibited by the presence of scarring. They can be performed under local anesthetic and the initial recovery time is much shorter. However, the long-term patency is probably less, and so endovascular repairs are often viewed as less durable in the long term. Thanks for watching. The revision notes are available free to download at vasculartutor.com. Don't forget to throw the video a like, and if you want notification of new videos as they upload, remember to subscribe.